Welcome to Podmedics. For this and other podcasts, please visit www.podmedics.co.uk. So hello and welcome to this emergency podcast on acute renal failure. During this podcast, I'm going to have a look at the definition of acute renal failure, the most important causes, the presentation, and then go through some of the basics of management. So, acute renal failure may basically be defined as an acute and significant impairment of renal function. Specifically, the important components to be aware of are that this is an acute condition, so coming on over hours or days, and represents deterioration in renal function as defined by either a rise in urea and creatinine or anuria or oliguria. Importantly, however, note that anuria and oliguria are not necessary for the diagnosis of acute renal failure. There are no real hard or fast rules about the biochemical components that you need to diagnose acute renal failure. However, some that have been suggested include a greater than 44 micromole per litre rise in creatinine over a baseline or a greater than 50% rise over the baseline. So, what are the important causes of acute renal failure? Traditionally, we can divide these into pre-renal, renal, and post-renal. It's important, however, to be aware of the significance of each of these sets of causes. 90% of acute renal failure is caused by pre-renal failure, and therefore this is the most important thing to exclude when presented with the patient in acute renal failure. The renal causes, all of those complex vasculitis syndromes and autoimmune phenomena, are quite rare in comparison, and post-renal causes, although significant and important to recognize, are also relatively rare. It's also important to remember that acute renal failure can occur because of a combination of the above factors. For example, post-surgical acute renal failure may be due to a number of factors coalescing to lead to the final clinical picture. For example, there may be fluid depletion, systemic infection, and the administration of various nephrotoxic drugs that may all be contributing to the picture that you see. So let's go through each of the different sets of causes of acute renal failure. First of all, and as we said, making up 90% of acute renal failures is pre-renal, and this really represents renal hypoperfusion, which may be due to any cause, but the important ones to be aware of are things like fluid depletion, sepsis, renal artery obstruction, and a decreased cardiac output. Unsurprisingly, because this is so common, it is the most important thing to know about as a house officer. Going on now to renal and intrinsic causes, as I said, these are, from a practical point of view, very rare. However, it's important to be aware of these. I've done a podcast on renal pathology previously, which if you want to get more information, more detailed information on these, you should go and listen to. However, broadly, it's useful to divide up these things into 4 categories and then think of a number of causes in each category. First thing you need to think of is acute tubular necrosis that may be due to prolonged ischemia of the nephrons. Next, think of tubulointerstitial nephritis, which may be due to hypersensitivity reaction or various drugs. And there are 3 important drugs to remember: NSAIDs, typically long-term use of NSAIDs, the aminoglycoside antibiotic gentamicin, and IV contrast media. Next thing to think of is vessel disease. And there are a number of phenomena that occur under this. For example, all the vasculitides, malignant hypertension, hemolytic uremic syndrome, and renal vein thrombosis. Lastly, and not least importantly, glomerulonephritis should also be considered under renal or intrinsic causes of acute renal failure. So finally, moving on now to post-renal, which, as we said, makes up about 10% of causes. As I said, these are quite rare, but it's important to exclude them as often they are correctable things. There are three things to remember, three things that can obstruct urine flow out of the kidney. These are stones, tumours, and prostatic hypertrophy. And the best test to find out if there is post-renal obstruction is to do an ultrasound of the kidneys, ureters, and bladder. The important complications of acute renal failure really stem from the fact the kidneys are unable to fulfill their usual function. Therefore, you develop a uremia, an electrolyte aberration, or electrolyte aberrations, most importantly acidosis and hyperkalemia, and fluid overload, as the kidney is not producing significant urine. The presentation of acute renal failure can really be quite vague, with non-specific features such as fatigue, vomiting, and pruritus. Often these things are attributed to the build-up of various toxins that are unable to be disposed of by the body. Specific things, however, include symptoms of fluid overload, such as dyspnea, orthopnea, and PND, and things that are particular to uremia. These include confusion, hiccups, and pericarditic chest pain. On examination, you of course want to do a fairly thorough general examination, but be on the lookout for specific things, such as signs of fluid overload. Signs would be, say, bibasal crepitations, a raised JVP, perhaps ankle edema. Be on the lookout for pericardial rubs that may indicate a degree of acute pericarditis in association with the uremia. There may be a full bladder, indicating possible prostatic obstruction, and also there may be polycystic kidneys, vasculitic rashes, and various other subtle clues to the cause of renal failure. There are three important things from an investigative point of view to do. Firstly, you want to establish the diagnosis. And as we said earlier, this is usually done via the urea and electrolytes. Next, you want to exclude some of the serious complications of acute renal failure. And last, you want to establish the cause and treat it. So, as we've said, we've already diagnosed acute renal failure with our U&Es. We now want to exclude the serious complications. And there are three of these to have in your mind: hyperkalemia, acidosis, and fluid overload. With hyperkalemia, you obviously want to detect a high potassium, so this will be on your normal U&Es, but you also want to do an ECG, looking for the typical ECG changes. These are a long PR interval, long QRS, tented T waves, and more seriously, a sinusoidal pattern on the ECG that may deteriorate into a ventricular tachyarrhythmia, such as fibrillation or tachycardia. Under acidosis, you want to perhaps do an arterial blood gas or venous bicarbonate. For fluid overload, you of course want to do a chest X-ray. Next, you want to look for more specific things that could tell you why the patient has gone into renal failure. The first thing to do is to do urine examination. You want to do microscopy of the urine, looking for cells, casts, and also culture of the urine, looking for infection. There's also a whole load of blood tests that you want to do. In addition to your standard FBCs, U&Es, etc., you want to think about perhaps doing immunological bloods, including ANAs, double-stranded DNA, anchors, complement, and anti-glomerular basement antibodies. This is commonly known as a vasculitic screen. Other important things will be albumin, which may be low, say, in nephrotic syndrome, CK, which may be elevated in rhabdomyolysis, and calcium that may be significant in a variety of disorders. You also, of course, want to think about imaging tests, and as we mentioned, the most important one of these really is ultrasound of kidneys, ureters, and bladder to try and pick up that 10% obstructive cause. So, the treatment strategy is really quite simple initially. you want to treat the life-threatening things. So, as we said, there are 3 important life-threatening things to pick up on. Remember, hyperkalemia, acidosis, and fluid overload. First of all, hyperkalemia. I've done a specific emergency podcast on this, so go and have a listen to that for more detail. But there are 2 basic concepts in the treatment of hyperkalemia. Because a high potassium predisposes to the development of cardiac arrhythmias, you want to try and stabilize the myocardium. And you do this with 10 mils, 10% calcium gluconate. The next thing you want to do is to try and get rid of this irritant potassium that's in the blood. And to do this, you drive it into the cells and or mop it up. To drive it into the cells, you use insulin and dextrose. And to mop it up, you can use salbutamol or calcium resonium. If these don't work, you can finally dialyze the patient. Fluid overload, once again, there's another podcast on this that you can listen to. However, it's important, if this is the case, to stop any IV fluids that the patient is being given. This will only contribute to further complications. To give high-flow oxygen, or CPAP if this is appropriate. Morphine, between 2.5 and 5 milligrams, depending on the state of the patient. 10 milligrams of metoclopramide, of course, should always be given with this. Give a diuretic, so 80 milligrams furosemide IV, and then think about giving a GTN infusion and titrate this to keep the systolic above 90 millimeters of mercury. So the last complication, the last life-threatening complication, is acidosis, which, if severe enough, may be treated with 50 mils of 8.4% sodium bicarbonate. However, senior advice should always be taken before giving this. Acidosis is also a possible indication for dialysis. Then, in terms of treatment, we move on to the stuff that we can deal with. So, as we said, pre-renal causes are the most important ones, and the aim in treating pre-renal causes is to prevent the development of acute tubular necrosis. So when you're assessing pre-renal causes, you want to look for any signs of dehydration that may suggest this. So pool peripheries, a prolonged capillary refill, dry mucous membranes, elevated heart rate, JVP that's down, and perhaps a postural blood pressure drop. Pre-renal renal failure is also associated with a urinary sodium less than 20 millimoles and a concentrated urine relative to the plasma osmolality. Typical ratio would be 1.5 to 1. In the treatment of pre-renal failure, you want to put a urinary catheter in to monitor the output and to give IV fluids. Your IV fluid strategy should consist of resuscitation and maintenance. Under resuscitation, you want to give repeated fluid challenges, and these are usually between 200 and 500 mils over 30 minutes. And then once you're getting a good output, you want to set the infusion to 20 ml plus the previous hour's output. It's important to remember, however, that patients, when they're recovering from a pre-renal renal failure, may go into a polyuric phase, at which point the rate they're given the fluids may need to be increased. You also want to think about CVP monitoring, so seek senior review. Now moving on to post-renal causes. If there is an obstruction that is detected on your routine KUB ultrasound, you're going to need a urology referral because the patient may need a nephrostomy to relieve the pressure associated with one of the blocking factors. If the cause is renal, or if you suspect the cause is renal, then you're going to need to get some specialist nephrology input early. And important investigative and therapeutic strategies are going to include things like renal biopsy, steroids, and immunosuppression, but I don't really want to get bogged down in this here. It's also important to be aware of the indications for hemodialysis, and these are the situations where the complications really have got so severe that you need to be treating uremia quite seriously. So the 4 things are a severe hyperkalemia, so a potassium persistently greater than 6 millimoles per litre, severe unresponsive pulmonary edema, symptomatic uremia. As you remember, we said that uremia can cause pericarditis, confusion and hiccups, so look out for these things. And finally, severe acidosis, either represented by a bicarbonate less than 15 or a pH less than 7.2. So, in summary, acute renal failure is an acute and significant drop in the glomerular filtration rate. The causes can be divided into pre-renal, renal, and post-renal. However, pre-renal is the most common by far, making up 90% of causes. Symptoms in ARF are relatively non-specific. Complications to investigate and treat are hyperkalemia, fluid overload, uremia, and acidosis. Always consider excluding post-renal causes during your investigative strategy. If patients are very sick, it's also important to refer and get specialist help as early as possible. So, thanks for listening to this podcast. See if you can fill in what our friend on the right is saying, and hopefully that will make you remember that renal causes of acute renal failure are not particularly common. Visit the site at www.podmedics.co.uk. Email me if you have any questions, ed@podmedics.co.uk, and I hope to see you soon.